Hello, everybody. Hope you're staying warm on this very cold Friday morning. My name is Sam. This is my clinical presentation of Welcome to Work. You're a staff RT at Keefe Memorial Hospital in Cheyenne Wells, Colorado. So, round one, let's go ahead and get into this. You are getting ready to sit down after a busy first round and finally eat breakfast and lunch combined when your pager buzzes off the counter. You are called down to the ER to help evaluate a patient being brought in by EMS from a clinic across the street having shortness of breath and chest pain. What do you want to set up in the room for this patient? Select as many as appropriate. So we have everything in here from oxygen to suction, urinary catheters to chest tubes, to ABG setup, IV equipment with blood tubes, cardiac monitor with pulse ox and end tidal, AED if you want a mass transfusion with blood, if you want a flow inflating bag or a self-inflating bag. Do you want the chaplain there? Do you want your stethoscope? Do you want your ophthalmoscope? Do you want Brazo tape? And do you want medications like your morphine and your aspirin? Give you a little bit. This slide has a lot of options, but again, this is before the patient gets to the room. So what can you set up before the patient gets to you so that you're not kind of assessing the patient, running over, grabbing something, assessing the patient, running over, grabbing something else. Everything's kind of there, close at hand. So if you need it in an immediate instant, you have it there to use and to utilize. Alright, so our choices do matter, like I said. Oxygen definitely is a good thing to have. Suction is a good thing to have. Urinary catheter, again, that's not something immediate, urgent that we're going to need to do. Chest tube, since he's coming from a clinic across the street, I don't think he's gonna probably need a chest tube right away. And if he does, hopefully you'll have a little bit more help in the room to get that set up for the doctors. ABG setup, if you did select this, I went ahead and gave you 0, so I didn't take any points away. If you want it, it's a good thing, but I know for our main clin sims, they always say defer the ABGs to later. IV equipment, absolutely, we'll always need access to our patients if we want to give medications or if we want to do lab tests or things like that. So cardiac monitor is very good to have. AED, don't necessarily need the AED off the wall. Typically ERs have code cards that they need, so again, didn't take any points away from you for that. I gave you 1 point for both the flow inflating bag and the bag valve mask. So if you pick both of them, you get an extra point. If you only picked one of them, it's not a big deal. Chaplain went ahead and did a 0 on that one as well, just because hopefully this guy's not going to die right away, but it gives the chaplain enough time to get to you if needed. Stethoscope, absolutely, we always need our stethoscope. Be able to see what's going on with our patients. Ophthalmoscope, that's the one scope that the doctors put in your ear to look and see what's going on down in your ears. Since he's having shortness of breath and chest pain, I don't think he's having anything going on with his ears, but he might. Brazo tape, definitely not Brazo tape, that's used for pediatrics. Medications is always a good thing to have close by or on hand or know where they're at, kind of there. The mass transfusion, I went ahead and gave you -2 just because it's unnecessary for this case right away and inappropriate use of resources. So if you have a trauma patient that's coming in while this patient's in the room and you have the mass transfusion in the room with you plus the blood that's already checked out to that patient, you have to submit or return that blood back to the blood bank. They have to log it in, test it, check it, and then they can resubmit it or reissue it to the other patient in the other room. So it would just delay care for anyone else. So only get it if you absolutely need it. So in the ER, your patient arrives in the ER via ambulance from the small clinic across the street. where he was waiting for his trainee to complete a physical to become a full-fledged trucker. The patient states, "I was sitting in that damned waiting room for hours when I got up. This sharp pain on my chest just hit me like when you get sucker punched in a bar fight. Took my breath away. EMS was only able to obtain non-invasive blood pressure of 140 over 92, heart rate of 114, respiratory rate of 25, labored, no IV, and no O2 currently on the patient." So with this, these are your first options. Obviously, there's a lot more that you would definitely want to do and kind of see and double check, but these are the options that I went ahead and gave you on the first round here. And so those include the cardiac monitor, so putting that patient on a cardiac monitor with a Q5 minute vitals, so your heart rate, your respiratory rate, your pulse ox, your blood pressure, your temp. Do you want to get a medical history from this patient? Do you want to give them an NPA with 15 liters via nasal cannula? Do you want to check their general appearance? Do you want to do a chest x-ray? Do you want to do a clean catch urine? Do you want to do an ABG at this time? Do you want to do needle decompression? And do you want to listen to breath sounds? Give you a second to select those. Alright, so your results for these, so I'll give you +3 for your vitals, because those are always important, especially that Q5 minute for an unstable patient. So your heart rate is 117, your respiratory rate is 24, non-invasive blood pressure is 136 over 90, SpO2 is 87 on room air, temp is 37, and then I gave you +1 for your medical history, so has a history of hypertension, non-insulin dependent diabetes, your factor V latent disorder, 40-pack year smoking history. So I also gave you +1 for checking his general appearance. It's always good to do, plus you would be doing it anyway just being in the room. Patient is alert and oriented, ×4, tripoding in bed with accessory muscle usage. Skin is cool, clammy, diaphoretic. He's clutching at his chest. So he's kind of sitting there on the bed, tripoding, head over, really working hard to breathe. So I'll give you +2 for that chest x-ray because we don't know what we don't see. So it shows hyperinflation with flattened diaphragm with infiltrate in the lower right. +2 for breath sounds because again, you can't hear something, you don't know what's going on. So clear upper lobes, unfortunately, and then diminished crackles in the bases. Doesn't really tell you too much, but it gives you a starting point. So 0 for that ABG, not assessed at this time. -1 for that clean catch urine, just because we don't need to be doing that. -2 for that NPA and the nasal cannula. This patient doesn't need an NPA. He's protecting his airway. He's alert and oriented. And 15 liters through a nasal cannula, that's quite a bit of flow going through the nasal cannula. Oops, pardon me. Went to -3 for that needle decompression just because he has no outward signs and symptoms of hemopneumothorax. So there's no need to, and his history doesn't support the trauma or anything along those lines to say he needs a needle decompression. So here's that chest x-ray. They went ahead and did a frontal and lateral for you guys. So you're able to see here, there's spine, there's your diaphragm, there's your heart here. And this is what they're calling kind of infiltrates over here in the lower right. And then again over here, kind of in this area. So from here, what's your plan of action? So the patient's still in the ER, sitting on the side of the bed still. Most recent vitals, so heart rate is now 120, respiratory rate is 26, non-invasive blood pressure is 130 over 88, SpO2 is 84% on room air, because we still haven't given him any oxygen yet. And patient states it's getting harder to breathe, and the pain in his chest is getting worse. So, from here, what do we want to do? We have options over here of get an EKG, sedate and intubate, IV bilaterally 18 gauge, CBC, O2 3 liters TTO, sputum collection, CPAP with self-inflating bag, titrate with SpO2 greater than 90%, history of previous heart attacks or strokes, and troponin. Okay, so for the results for that, so the EKG we went ahead and got, it was a sinus tachycardia with occasional PVCs. So it was a fast heart rate. This most recent vitals heart rate was in the 120s. So that is tachycardia, almost up to supraventricular tachycardia or SVT, and then with occasional PVCs. So he's got premature ventricular contractions. His heart's pissed off, basically. +1 bilateral IVs, so it's always good to get IVs on a patient, and bilateral IVs if you want, or if your patient is unstable, because you're not sure what's going on. Is there bleeding? Like, are you going to have to give medications quickly? What else going on with that? +2 for your CBC, which it did show polycythemia, no increase in bands and then a normal white blood cell count. +1 for the sputum here, so it does show streaked hemoptysis, and that will come important here a little bit later. And so titrate to 90%, and further history of blood clots due to factor V disorder. Last DVT was 6 months prior, not currently taking his Coumadin for the last 2 weeks due to being away from his normal pharmacy. The finger stick in the ER shows PTT or prothrombin reads low. So basically, factor V is a clotting disorder. So it's a genetic disorder that people are born with. Basically, they form clots very easily. So for them, sitting down and doing that is equivalent to us sitting down for a longer period of time. So they clot quicker, and they clot more often. So they have histories of DVTs, heart attacks, strokes, pulmonary embolisms, things along those lines, that wherever you could form a clot and get it lodged, they've had it. So your +1 for your troponin, it's normal. It's always good to, I gave you +1 because it's always good to double check it and just make sure that it's not the heart, because again, with this factor V, it may be in the heart and he may be having a heart attack, but with the SVT, occasional PVCs, still may be the heart. -3 for the sedate and intubate, and then -2 for TTO. It's not indicated. Also, I wanted to kind of touch back on this. If you picked CPAP with self-inflating bag, that was going to be a negative, because number one, you can't do CPAP through a self-inflating bag. If you remember back to Therapeutics 1, you have to have a flow inflating bag to give CPAP through. Alright, so your continued reassessment. Patient's vitals are now heart rate of 126, respiratory rate of 20, blood pressure of 124/80. Pulse ox is now at 92% on 4 liters nasal cannula, because we were able to give him titrate up to 90%. Now he's over that at 4 liters. So patient's respiratory rate is slightly decreased from where he was, however still complains of shortness of breath with breath sounds unchanged. So he's still struggling to breathe, but nothing's changing as far as his breath sounds. Stabbing chest pain still. So the skin is cool and clammy, but he doesn't have any cyanosis, because again he's now oxygenating that tissue. Unfortunately, with you being at a critical access hospital, typically they will only have one CT in that hospital. Unfortunately today, that CT is down for unscheduled maintenance, with the backup on its way from Colorado Springs with a 3+ hour ETA. They have little CT MRIs in a semi-trailer basically that they bring to hospitals. They'll park there for a little while, and the hospital can use it if they need an extra CT. What further tests or scores would you like to obtain? So your options over here are tell the patient to sign out AMA and drive to the next town for proper medical care because your CT is down. Obtain an ABG, obtain a D-dimer, give this patient a spinal tap, do a VQ scan, pick your Wells criteria, and do a FAST exam. So for your results over here, so your ABG, at this point it is good to get an ABG, see where they're at, where they're going, are they getting better, are they getting worse. So 745, CO2 20, because he's blowing off that CO2. Bicarb is 40, so that has what looks like past history with being a smoker and hyperinflation. So +1 on the D-dimer, so it shows that it's positive, or he is forming clots currently, but we kind of already knew that because of his factor 5. So +2 for that VQ scan. So if you don't have a CT or CTA, the VQ scan is the best option, and it used to be the primary option before CTA really became as popular as it is. +1 for the Wells criteria. He's greater than 6, which is and has a 40% chance of a PE, or pulmonary embolism. Gave you a -2 if you picked a spinal tap. There's no need. He didn't have any white bands or neutrophils or anything kind of before, so doesn't really need a spinal tap. -1 for a FAST exam. So a FAST exam is where they take an ultrasound and look in the belly, look in the chest for any free fluid. So it's not really looking for clots, more looking for bleeding or just free fluid in those cavities. So that's what they're looking there. And then -10 to tell the patient to sign out AMA and drive to the next town for proper medical care. Again, even though the CT may be down, you still have appropriate options. And like I said, the VQ scan used to be the gold standard before CTAs really became as efficient as they are. So here's that VQ scan. This over here is your chest x-ray. Kind of again shows that infiltrates kind of in this lower right side here, and then your VQ scan shows the perfusion that's decreased to that side. Again, this is flipped because this is looking at the back, that's looking at the front. So for your Wells scoring system, this is the Wells criteria for suspecting, ruling in, ruling out DVTs. You have your clinical symptoms of a DVT. So if he had swelling in his leg, swelling, redness in his leg, pain in his leg, or something along those lines, that would give him an automatic 3 points. A PE is your first diagnosis or equally likely, you get a 3. So with everything, he gets at least a 3. Heart rate is greater than 100 beats per minute. Well, he's tachycardic at 120 beats per minute. Immobilization at least 3 days or surgery in the previous 4 weeks gets 1.5. Previous or objectively diagnosed PE or DVT, he has a history of one that was 6 months prior, so he gets another 1.5 there. Hemoptysis, he gets a 1. And then malignancy, he gets a 1. He's at a high risk category if he's greater than 6, moderate is 2 to 6, and low is anything less than 2. So from here you have your medications and your plan. So now that you have this information, what would you like to do now? So the patient's current vitals are heart rate of 120, respirations of 20, non-invasive blood pressure of 118 over 74, SpO2 of 88% on 4 liters, no other clinical change that you note. So do you want to admit this patient to hospice on strict bed rest? Do you want to change the patient from the nasal cannula to an oxy mask and titrate to 90%? Do you want to give this patient some compression socks? Do you want to give this patient heparin and warfarin? Do you want to give this patient a duoneb? Do you think ambulation and fluids is a good idea? Do you want to give fibrolytic or clot busting medications like TPA? And do you want to transport this patient to a higher acuity hospital? Again, this is select as many as appropriate. Alright, so your plan, so admit to the hospice and strict bed rest is a -3. He's not dead yet, so we're able to do what we can to save him and get him better. So +3 to change the patient from the oxy mask and titrate to 90%. As you saw, he dropped from 94% on 4 liters to 88% on 4 liters. So his oxygen needs need to go up or have gone up. +1 on the compression socks. So those are always good to have on patients that are in bed, and that kind of helps with return circulation since he's not really up walking around too much. And with that, get him up walking around. You got this +1 with ambulation and fluids. But +2 for your heparin and warfarin. So this patient normally takes warfarin for his factor V. He's just out of his medications currently. So get them back on medication that will help prevent those clots. Go ahead and give him a fibrolytic or clot busting medication like TPA. That's really the big treatment there, or surgery and so and then number 2, transport to a higher acuity hospital. You don't have the options at this hospital to do surgery if you need, as well as like your biggest thing is kind of probably the heparin and warfarin. So get that patient back stable on some medications. Congratulations, it's a pulmonary embolism. Not the coolest and greatest thing in the world, but a lot of good information. Kind of go from there. Definitely mimics a heart attack in a lot of cases. These are typically your pinpoint chest pain. So if someone can say, and with their finger point directly to a part on their chest and say, "I have chest pain here," that can be a sign that they have pulmonary embolism. And then getting a really good history and physical is also important to kind of say, this is what I got, this is what's going on, this is what I've done in the past, and he's sitting for extended periods of time. So I think long distance trips, bus trips, car trips, airplane rides, things like that you're going to be sitting for a while. Also those genetic disorders like your factor V disorder, which increases your risk of blood clots, and just them sitting down will create a clot, and those patients will also be on blood thinners as well. So that's something also important to know. If they have factor V and they're coming in, if they're therapeutic with their blood thinners or even overshot the mark, they may not be able to clot, and so you're having to put a lot of pressure on bleeds or anything like that. These are my references here that I got for this slide. Thank you very much for your time.